So starting off with the oral cancers first. So in the oral cancers, the most common type of oral cancer is going to be the squamous cell carcinoma. Now, when we're talking about squamous cell carcinoma, it is differentiated into two types, that is whether it's a well differentiated or poorly differentiated. It depends upon the number of keratin pearls. More the number of keratin pearls, well differentiated it is. Lesser the number of keratin pearls, it is poorly differentiated. The most common gene that is involved in oral cancers is going to be the p53 gene. Now, very important is the sites where it is most commonly seen. It is differs in India and worldwide. In India, it is present at the level of buccal mucosa and at bucco-gingival sulcus, and the buccal mucosa and at the bucco-gingival sulcus. While worldwide, it is found at the lateral border of the tongue. Now, there are multiple risk factors for this oral cancer. They include tobacco, alcohol, betel quid chewing, right? Then the infections like the Epstein-Barr virus, human papilloma virus, candidiasis. Now there is something called dentures. So sharp or ill-fitting dentures, they can cause constant irritation to the oral mucosa, and that can lead to oral cancers. Now, human papilloma virus and the associated tumor. So, human papilloma virus, it can lead to oral cancer and oropharyngeal cancer, out of which the oropharyngeal cancer, it has got a better prognosis. The associated tumor is going to be the verrucous carcinoma, which is a variant of squamous cell carcinoma. It is also called as the Ackermann's tumor. Now, the pre-malignant lesions, they have been divided into high risk, medium risk, and low risk. The high risk, it consists of hyperplastic candidiasis, leukoplakia, and erythroplakia. Medium risk, the examples of medium risk are oral submucous fibrosis and syphilitic lesions. Then the low risk groups, they consist of oral lichen planus and the discoid lupus erythematosus. Now, talking about the high risk lesions first. So, the first very important differential lesion is candidiasis versus leukoplakia. So, candidiasis, it can be rubbed off. Leukoplakia, it cannot be rubbed off. Right? Leukoplakia, what is the management for leukoplakia? It's going to be carbon dioxide laser or cautery. And there are two types of leukoplakia. The first is going to be the proliferative verrucous variant. The proliferative verrucous variant, it is associated with about 3 to 4 times more association with cancer. It is not associated with typical risk factors, and it is going to be multifocal in nature. On the other hand, the second type, that is called as a speckle type. Speckle type, it has a less chances of going into cancerous, but however it also shows malignant change. The next is erythroplakia. Erythroplakia overall has the maximum chances of going into malignancy. About 5 to 6 times the chances are present. It is nothing but a red patch that is seen, which cannot be rubbed off. The type, the speckled variant. The speckled variant, out of all these three, it has the highest chances of converting into a malignant. Then factors that are associated with increased risk for malignant change in the pre-malignant conditions. So those factors, they include a female sex, then those who are non-smokers, if the location of this change is in the lateral border of the tongue, then if the tumor size is more than 200 millimeters, and if the pre-malignant change is multifocal in nature and non-homogeneous lesions are present. So these are the risk factors that are associated with increased malignant change. Now, talking about oral submucous fibrosis is seen in betel quid chewing. The management for this condition is going to be intralesional steroids, that is intralesional triamcinolone. Never go for the excision of these fibrotic structures. Why? Because again the body will heal by excessive fibrosis, and this will lead to even more problems. And next is the Plummer-Vinson syndrome. So Plummer-Vinson syndrome, it is a triad, right? It is also called as Patterson-Kelly-Brown syndrome or syndromic dysphagia. It consists of iron deficiency anemia, then it consists of angular cheilitis or glossitis, and post-cricoid waves. So this post-cricoid waves are the reason why dysphagia is present. The cancers that are associated with it, it is more commonly present in the perimenopausal women, and the cancers that are associated with it are the hypopharyngeal carcinoma and the esophageal squamous cell carcinoma. Now there is a topic called as field cancerization. Field cancerization means that the whole mucosa is getting affected in that particular region. So this field cancerization is seen in three structures. First is the oral mucosa, then it is found in the bladder mucosa, and the third structure is colorectal region. The types of field cancerization, that is synchronous or metachronous. In synchronous, it undergoes cancerous change within 6 months, and in metachronous type, it undergoes malignant change after 6 months. Then oral cancer. In the oral cancer, the diagnosis of choice is going to be the incisional biopsy. Incisional biopsy is never taken from the center. Why? Because in the center there is going to be a necrotic area. It is always taken from the edge, or the wedge biopsy is preferred. Now the investigation of choice for staging is going to be the CCT, that is contrast on CT of PNS, head and neck. Then TNM staging. Very important is this TNM staging. So the TNM staging, there are T1, T2, T3, T4 stages. These stages, they depend upon the size of the tumor as well as the depth of invasion. So the T1 stage is where the size of tumor is less than 2 cm and depth of invasion is less than 5 mm. T2, the T2 is further divided as T2A and T2B. In T2A, the lesion is still less than 2 cm, but the depth of invasion is 5 to 10 mm. In T2B, the size of the tumor is 2 to 4 cm and the depth of invasion is less than 10 mm. In T3, the size of the tumor is more than 4 cm and the depth of invasion is more than 10 mm. In T4, it is going to spread, right? So in the T4, it is a resectable structures, it spreads, for example, the mandible, and in T4B, it spreads to unresectable structures like the base of skull. Then the lymph node status. NX means the lymph nodes have not been assessed. N0 means no lymph nodes are involved. N1 is ipsilateral lymph node less than 3 cm in size. Then N2 is further divided into N2A, N2B, N2C. N2A means ipsilateral lymph node of 3 to 6 cm in size. N2B means it's going to be ipsilateral lymph nodes but multiple lymph nodes of less than 6 cm in size. N2C is contralateral or bilateral lymph nodes of less than 6 cm in size. Then N3 means more than 6 cm size. It is further divided as N3A and N3B. N3A, there is extranodal extension. N3B, there is going to be matted lymph nodes, or the lymph nodes that are added into the skin. Then talking about the metastasis, M0 means no metastasis, M1 means distant metastasis is present. The most common site of metastasis is going to be the lungs. The most important prognostic factor is the lymph node status. Talking about the management of oral cancers, so in the management of oral cancers, it's either surgical or chemo, radio, immunotherapy. So talking about the surgical management first, the first is going to be the commando procedure. In the commando procedure, first we go for wide local excision with a margin of 0.5 cm. R0 resection is to be done, followed by lymph node dissection, followed by neck dissection. So it is a very long procedure, so it is called as commando procedure. Then if it's involving the lip, if it's involving less than 1/3 of the lip, then we go for wide local excision and primary closure. If it's involving 1/3 to 2/3 of the lip, then the procedure is called as Johnson's step procedure. Then if it is involving more than 2/3 of the lip, then we go for flap reconstruction. Now there are different approaches to this. So over here, the first is, this is called as the visor approach. In the visor approach, we can easily resect the mandible and the floor of mouth is visualized. Next is the Weber-Ferguson approach. In the Weber-Ferguson approach is generally done for upper lip. Easily the maxillectomy can be done. Then the next is the lip split approach. This lip split approach is the most common type of approach that is preferred. Then talking about the levels of lymph nodes in the neck. So in the levels of lymph node in the neck, there are 7 levels. So 1A is submental, 1B is submental, then 2 is upper deep cervical or upper jugular, 3 is middle deep cervical or middle jugular, 4th is lower deep cervical or lower jugular. Then all these lymph nodes, they lie in the anterior triangle of neck. Then the level 5 lymph node is the largest group of lymph node. It is located in the posterior triangle of neck. Level 6, it consists of pretracheal and paratracheal lymph nodes, which lies in the central region. So they are also called as central nodes or Delphian nodes. They are the sentinel lymph nodes for the laryngeal cancer and thyroid cancer. The level 7 lymph nodes are present in the mediastinum. Now when we talk about the neck dissection, these are the different approaches. So over here there is a Cryle's incision. Then Martini's incision looks like a wine glass. Okay, then hockey stick incision, and then McAfee's incision. Most common type of incision that is shown over here, this is called as the modified Schobinger's incision. In the modified Schobinger's incision, you can see that from the angle of mandible, 2 finger width distance is present. This is done for preserving the marginal mandibular nerve. Now there are different types of neck dissection. The first is a radical neck dissection. The radical neck dissection is a dissection where level 1 to level 5 lymph nodes, they are cut off. Apart from that, the tip of parotid gland and submandibular gland is removed. and the cis structures are removed. Cis structures that include the spinal accessory nerve, internal jugular vein, and the sternocleidomastoid muscle. So if all of these things are removed, then that is called as a radical neck dissection. Modified radical neck dissection means if any of these cis structures are preserved. MRND1 means one structure is preserved, MRND2 is two structures are preserved, MRND3 means all these three structures are preserved, and that is called as functional neck dissection. Then there are selective neck dissections, SOHND, that is supraomohyoid neck dissection, where lymph nodes 1 to 3 levels are preserved, they are dissected, and central neck dissection is where the level 6 lymph nodes are dissected. Then the complications of oral cancer, the first is bleeding, then the next is infection, and the injuries. The injuries, they are given by this mnemonic PSMH. So P stands for the phrenic nerve, S stands for the spinal accessory nerve, so that will lead to drooping of shoulders, M stands for the marginal mandibular nerve, that will lead to drooping of the angle of mouth, and H stands for the hypoglossal nerve. Then apart from that, carotid artery blowout can also be seen in oral cancers. Now the flaps that are used, so there is a deltopectoral flap, then pectoralis major myocutaneous flap. This is the most common type of flap that is generally used for oral surgeries or oral cancer. Abbey slender flap, it is used for for the lip cancer and from the angle of mouth tumor. Free flaps, the free flaps, they are radial artery forearm flap, which is the most common flap. Free fibular flap, this is generally used for reconstruction of the edentulous mandible. It is for reconstruction of edentulous mandible that is having no teeth. Now metastasis from unknown primary sites. What is meant by metastasis from unknown primary sites? So sometimes metastasis can be seen, but we cannot know the unknown primary sites. Nowadays it is possible because of the PET CT, but however earlier it was not possible. Now we should know about the hidden sources. So if it's not possible, you should check for the hidden sources. The hidden sources for this, they will be the base of tongue, tonsillar fossa, pyriform fossa, then it will include fossa of Rosenmuller and the retromolar trigone, that is the space behind the third molar. Now talking about the other methods, that is the radiotherapy, chemotherapy, the indications are extranodal extension, lymphovascular invasion, perineural invasion, and if the margins are positive. Then there is concurrent chemoradiotherapy, which has got a better prognosis. Neoadjuvant chemotherapy, where chemotherapy is given before the surgery, and immunotherapy, which includes the PDL1 inhibitors. Now the next is the difference between the dentigerous versus dental cyst. So dentigerous cyst is caused because of unabrupted tooth. Generally it's the most common is the third molar tooth, and management is enucleation of that unabrupted tooth. Then dental cyst is caused because of dental caries, and we have to remove the carried tooth for it. Ameloblastoma is nothing but a tumor of the mandible, bony mandible. So the investigation of choice is the OPG, that is orthopantomogram. Then there are two scales, Karnofsky scale and the ECOG score. This Karnofsky scale and the ECOG score, they are used for checking the performance of the cancer patients, whether they are able to do their day-to-day activities or up to what level their activities can be performed. Then moving on further to the salivary gland. So in the salivary gland, we should talk about the origin of salivary glands first. Then the parotid gland is going to be ectodermal in origin, while the submandibular and sublingual glands are endodermal in origin. The ducts. So in the parotid gland, the duct is called as the Stenson's duct, while the Stenson's duct, it opens opposite to the second molar. Then the submandibular gland, the duct is Wharton's duct. This Wharton duct has got an anti-gravity drainage, and it opens opposite in either side of the frenulum. Now there are increased chances of stone formation in this Wharton's duct, and so submandibular gland. Then the lobes of parotid, there are two lobes of parotid, superficial lobe and deep lobe. There is a plane that divides, that is called as a faciovenous plane. It consists of facial nerve, external carotid artery, and a retromandibular vein. Accessory parotid, it is present in 20 to 60% of the individuals. There are chances of recurrence because of which, and so for accessory parotid, we should also remove these bits of parotid. The investigation to differentiate between the inflammatory lesions and the neoplasms is CECT, that is contrast enhanced CT. Then for siloliths, we use the non-contrast CT. To differentiate between benign and malignant, we use the MRI. But however, overall the investigation of choice remains to be the FNAC. So for this FNAC, we go for high resolution ultrasound guided FNAC. Then the FNAC criteria. The criteria for FNAC is called as the Milan's criteria, according to which the risk of malignancy is seen. So the criteria one, that is non-diagnostic. If it is non-diagnostic, then we have to repeat it and we consider that the risk of malignancy is 25%. Then the two is non-neoplastic. In non-neoplastic also the risk of malignancy is about 10%. In type 3 it is AUS, that is ATP of unknown significance. Over here the malignancy is about 20%. Then 4A is benign in nature. Here the risk of malignancy is the least, that is less than 5%. In 4B it is the SUMP, that is a salivary gland neoplasm of unknown significance or unknown, of uncertain malignant potential. Here 35% risk of malignancy is present. Then 5, it is going to be suspicious for malignancy with 60% risk, and over here malignant lesion were more than 90% risk for malignancy is present. So this FNSC criteria, Milan criteria, is important for salivary gland tumors. Now, before moving on to the malignant lesions, first the benign conditions. In the benign conditions, the first is going to be Staphy's bone cyst. In the Staphy's bone cyst, if you look at the X-ray picture, then we can see the cystic area that is hypoechoic in nature, and this is nothing but it's a site of ectopic salivary tissue. Then a very important benign condition that is called as ranula. Ranula literally means a frog belly. The gland that is involved is the sublingual gland, and the pathology is that there is a mucus extravasation from the salivary gland. It is fluctuant, it is transillumination positive. Management for this is excision of the sublingual gland itself, right? The complications is the most common structure that is affected, because of which is going to be the submandibular duct while excision, and the most common nerve injured is the lingular nerve. Then the plunging granula. Plunging granula is caused because of both the glands, that is submandibular and sublingual glands. The pathology over here is the mucus retention and not extravasation. The management for this is excision of the sublingual gland, but we cannot excise the submandibular gland, so there the the neck swelling is aspirated. Then the next condition is acute necrotizing xylometaplasia. Acute necrotizing xylometaplasia, the site over here is the hard palate, and minor salivary glands are involved. The character of the swelling is just like your umbilicated swelling the molluscum virus. So similar over here, redness from the surrounding, there's a swelling, and in center there is going to be a crater. So this is found in acute necrotizing xylometaplasia. Then parotid abscess generally found in diabetic patients or immunocompromised patients. Fluctuation, if fluctuation is seen, then that means it's a late sign. The management method is nothing but incision and drainage of this abscess, but at the same time we should take extra care by using the Hilton's method. So Hilton's method says that the incision should be made parallel to the important structure, and the important structure over here is the facial nerve. Then recurrent parotitis in children, it is seen in about 3 to 6 years of age. It is unexplained, and appearance on the ultrasound over here, what we get is called as the snowstorm appearance. The management is long-term IV antibiotics, and endoscopic washout should be given. Xylolids are the stones. The most common gland that is affected is submandibular gland, because it consists of Orton struct, which has anti-gravity drainage, and it is highly viscous secretions. Composition is highly viscous in nature. Then the composition of this stone, it is calcium phosphate. Investigation of choice is a non-contrast CT, and management. The first line management is the endoscopy using the Dormia basket. So this is generally done for less than 5 millimeters of the stone, but now even it is said that for more than 5 millimeters of the stone you should go for endoscopy with Dormia basket. If not, then second line management, that is called as the duct slitting, it is done. The final resort is going to be the excision of the gland. Then the next is salivary gland tumors. Now there is a general dictum that more the size of salivary gland tumors, more are the chances of it going to be benign. So generally parotid tumors are benign, while the minor salivary gland tumors, 90% of which are malignant. Now talking about the parotid tumors, they are going to be extremely painful in nature, except one, that is Warthin's tumor, which is painless because it is going to grow against the capsule, and capsule stretches that will lead to excruciating pain. It lifts the earlobe. Then the most common lobe that is involved is the superficial lobe. How can we how can we assess the involvement of deep lobe? So deep lobe involvement can be assessed with the help of the tonsillar fossa. We can see the tonsillar pillars, they have been shifted towards the medial side. So oral examination is important. Investigation of choice for any parotid tumor, it remains to be the FNSC. The most common benign tumor is pleomorphic adenoma. Most common in children is going to be cavernous hemangioma, and most common malignant is mucoepidermal carcinoma, followed by second most common, that is adenoid cystic carcinoma. Now starting with the pleomorphic adenoma. Pleomorphic adenoma is the most common tumor overall, and it is more commonly found in females around the fifth decade. On the histopathological examination, you will find this tumor as the triphasic tumor in the myxoid stroma. In the myxoid stroma, you can see the epithelial and myoepithelial components. Epithelial components, the IHC marker is cytokeratin 717, and myoepithelial, it is S100, SMA, SOX1, right? The management for pleomorphic adenoma is going to be superficial parotidectomy, as well as to remove the finger-like projections, otherwise recurrence might happen. If it turns to malignancy, then that is called as the mixed malignant tumor, or it is also called as carcinoma X pleomorphic adenoma. There is rapid increase in swelling, then there is going to be even severe pain, and involvement of the facial nerve is seen. Then Warthin's tumor, or it is also called as adenoma lymphomatosum, because of this lymphoid aggregates are seen. It is the second most common benign tumor. It is associated with smoking or radiation exposure. Generally found in males around 6 decades. It is painless in nature. Management is again going to be the same, that is superficial parotidectomy. Mucoepidermal carcinoma is found in second decade, so generally it is found in children and a young age group, young adults. The risk factors for mucoepidermal carcinoma are going to be radiation exposure in the childhood. Management, if it's a low grade tumor, then you have to just do parotidectomy, complete parotidectomy. If it's a high grade or intermediate grade where the margins are positive, then along with parotidectomy, radiotherapy is given. Then adenoid cystic carcinoma, it shows perineural invasion, so facial nerve involvement is very common. Then along this histopathological examination, you can see the cystic spaces which are clear in nature, so this is called as the Swiss cheese appearance. Swiss cheese appearance. Among the immunohistochemistry, you can find these ductal cells. So ductal cells, the marker is c-KIT, and for myoepithelial cells, we have discussed as SMA, S100 or SOX1. The management for this is going to be complete parotidectomy plus minus radiotherapy. Then surgery. So the surgery, the incision that is made over here, this is called as the Lacey's incision or modified Blair's incision. Then it is also made at 2 finger blades with the angle of mandible to produce the marginal mandibular nerve. Then there are different types of surgery. The first is going to be superficial parotidectomy, where it is generally done for benign conditions, and total parotidectomy, where the whole of the parotid gland is removed. Now, total parotidectomy is further divided into conservative and radical. So, total radical parotidectomy is where the facial nerve is also removed, and total conservative is where the whole of parotid gland is removed, but the facial nerve is preserved. Now, after removing the facial nerve in radical parotidectomy, we have to repair the facial nerve. So, this repairing of the facial nerve is done with the help of graft. The most common graft that is taken is just from the nerve, that is greater auricular nerve, while the best graft is sural nerve. The complications relate to hemorrhage, then injuries. So injuries to which nerve? Marginal mandibular nerve, greater auricular nerve, then facial nerve. How to prevent the injury to the facial nerve? By using the pointers. The best pointer is going to be a tragal pointer. So at the tragus of the ear, 1 centimeter below it and deep to it, there lies the facial nerve. Then after that, the next is going to be the posterior belly of digastric muscle, or retrograde, which is the worst method, but the most commonly used method is going to be the electrical nerve stimulators. They will help us to locate the nerve. Then the fistula. The fistula, that is divided into high output fistula and the low output fistula. The low output fistula generally develop from the glands and they close spontaneously. High output fistula, they develop from the ducts, and for them the management is called as the Newman and Brooks surgery. Then the Frey syndrome. The Frey syndrome is caused because of misdirection of the auriculotemporal nerve. Now this auriculotemporal nerve, the diagnosis is done by the star child dentist, and the management for this condition is generally conservative, or the definite management will be tympanic neurectomy. Extracapsular dissection. Extracapsular dissection is generally done to prevent the injury to the facial nerve. However, this can be done only in case of benign conditions. Then submandibular and the sublingual gland. The most common tumor overall in submandibular and sublingual gland we should talk. So submandibular gland, there is so the first is submandibular glands. In the submandibular glands, how to differentiate between submandibular gland swelling and lymph nodes? It is done with the help of bimanual palpation. Then the most common benign tumor is going to be pleomorphic adenoma. Most common malignant tumor is going to be adenoid cystic carcinoma. The most common tumor overall in case of sublingual gland and the minor salivary gland is adenoid cystic carcinoma. Why? Because the malignant tumor, the chances are more. Then management is going to be the gland excision. So submandibular gland excision or sublingual gland excision. Complications are hemorrhage, injury to the marginal mandibular nerve, which is the most common. Then lingual nerve and hypoglossal nerve. Facial artery is also involved and anterior facial vein. So these are all the structures which are affected in case of the surgeries that are done for submandibular and sublingual tumors. Now there are some named tumors and their description is given here. The Godwin's tumor. Godwin's tumor is the benign lymphoepithelial tumor. Eschimoma is a malignant tumor. Kuttner's tumor is chronic sialadenitis and oncocytoma. Oncocytoma, it is a rich in mitochondria. It shows hotspot on 99 technetium scintigraphy. Then there is something called a silosis or siloadenosis, which means a painless bilateral non-inflammatory swelling. That is called a siloadenosis or silosis. Then, so this is all about the maxillofacial surgery. Moving on to the next topic, that is the vascular surgery. So the first topic in the vascular surgery is going to be the deep VT, that is deep vein thrombosis. Here the anatomy of the lower limb veins is very important. So anatomy of the deep veins is that there is an anterior tibial vein, posterior tibial vein and a peroneal vein. They together three join to form a femoral vein. It is joined by popliteal vein, further it is joined by profunda femoral vein and it drains into the saphenofemoral junction and further it joins the external iliac vein. Now, the most common cause of death following bariatric surgery is the deep vein thrombosis. Risk factor is virchow triad. So in the virchow triad, we know that it's the stasis of the blood or the sluggish blood flow, then increased coagulability, that is hypercoagulability, and endothelial injury. So this triad, it forms the virchow triad, which is a risk factor for DVT. Then there are multiple patient factors like the age of the patient, then bedridden patient, female sex, high estrogen levels, OC pills. So these are the multiple patient factors that are responsible for DVT. There is something called as May-Thurner syndrome. How to remember May-Thurner syndrome is RIA जगू देत नहीं है. So the RIA stands for right iliac. The right iliac artery that is compressing the left iliac vein. That is, RIA is not giving me to live, right? So RIA जगू देत नहीं. Then the most common vein that is involved in the DVT is going to be the calf veins or the soleal veins. Then talking about the complications. So the complications, are two important complications of DVT: post-thrombotic limb and pulmonary embolism. Pulmonary embolism, it leads to sudden onset shortness of breath and all. The most common vein that is involved in pulmonary embolism is going to be iliofemoral vein. The proximal veins, they generally have a higher propensity of pulmonary embolism. The signs of DVT, they include the constant sign. Constant sign means there is a swelling. Generally the swelling is found to be pitting in nature and it is generally found below the tibial tuberosity. Moses sign is when we squeeze the calf muscles, the patient will have pain. Then Homan sign is on the dorsiflexion of the ankle, there is a resistance felt. Then there are two important terminologies called as phlegmasia cerulear dolens and phlegmasia alba dolens. Phlegmasia means pain, dolens means the lower limb. So cerulear means blue. So painful blue lower limb. It is formed because of the major axial veins. They are getting blocked. Apart from that, the collaterals are also damaged. So in these conditions, we'll find phlegmasia cerulear dolens. Phlegmasia alba dolens is found when the major axial veins are getting blocked, but the collaterals are patent. So in that, white milk leg or white leg is seen, and this is seen in case of pregnancy. Then what is the criteria for DVT? The criteria for DVT is called as the Wells criteria. Now the things that are seen in Wells criteria: the malignancy, then the bedridden, if the patient is bedridden for more than 72 hours or more than 72 days, if there is a major surgery within 4 weeks, or if there are prolonged surgeries like total knee replacement, total hip replacement, transplant surgeries, if entire leg is swollen, if the leg swelling is below the tibial tuberosity, if pitting edema is present, collateral superficial veins they are seen, or if there is a previous history of DVT. So these are the multiple factors, and only thing that we need to remember is if there is a IV drug abuser, then we give +3 points, and if there is alternative diagnosis which is least likely, then the points are +2. If the alternative diagnosis is more likely, then the points are -2. So this is the Wells criteria. Now the low probability over here, it is a score of -2 to 0. Then score of 1 and 2 is moderate probability, and score of 3 and higher is considered to be high probability for DVT. Then in the investigations, the investigation of choice for DVT is going to be the duplex scan. Duplex scanning consists of B-mode ultrasound and a color Doppler. For pulmonary embolism, the investigation of choices, can be invasive methods or non-invasive. Where it's invasive, it's a gold standard, that is pulmonary angiography, and non-invasive it's CT pulmonary angiography or MR angiography. Then the D-dimer levels are increased in DVT management. In the first 5 days, we have to give low molecular weight heparin as well as warfarin to the patient, and after 5 days, you have to just continue our warfarin. Now, it's contraindicated if there is bleeding diastasis to the patient. Now the duration after the previous episode, you have to continue it for 3 months. If it's a recurrent DVTs happen, then lifelong the treatment is given. For pregnant ladies, the warfarin cannot be given. So in this low molecular weight heparin, 4-vinylnox is given, and you can continue heparin till 6 hours before it. Then the sensitivity to heparin. So one has a sensitivity to heparin, then direct NA inhibitors can be used, or novel anticoagulants, that is apixaban, rivaroxaban, direct thrombin inhibitors like pyridine, deciridine can be used. Now if the patient presents early within 4 to 6 hours, right, and if it's a case of recurrent DVT, proximal DVT, then you have to go for thrombolysis. The drugs for thrombolysis, streptokinase and urokinase, right, and it decreases the risk of post-thrombotic limb. Now IVC filter. IVC filter is also known as the Greenfield filter. The indications for retrievable IVC filter are as a prophylactic in major high-risk trauma patients. Now when we are doing thrombolysis, there can be small bits that can go into IVC. So when we are going thrombolysis, it is used as a protection. And extensive ileocabal thrombosis, and if there are any complications of anticoagulation, then that particular thing, retrievable IVC filter is used. What are the complications of IVC filter? The most common complication is the migration of this filter, bleeding, and very important is the small clots. They can get saturated, and that can decrease the venous return, and the patient can go into decrease cardiac output and decrease SPP. Shock can happen. Then prophylactically, there is mechanical prophylaxis or pharmacological prophylaxis. Mechanical prophylaxis is motivating the patient for early ambulation and pneumatic compression stockings. The prophylactics or pharmacological management is low molecular weight heparin, or heparin should be given up to 6 hours before the surgery. Now the another complication is the post-thrombotic limb. So what are the clinical features of post-thrombotic limb? So in the post-thrombotic limb, it is found in about 66% of the individuals. Here the varicosities can develop, that is varicose vein can happen, lipodermatosclerosis, pigmentation. The risk factors for this, they are going to be a proximal DVT, recurrent DVT, and if there is subtherapeutic anticoagulation therapy that is given. So this is all about the lower limb DVT. After lower limb DVT, there is less amounts of upper limb DVT that can be seen. Upper limb DVT, primary or secondary, it is secondary to thoracic outlet obstruction or cannula. Primary, it is seen because of Paget-Trotter disease. Paget-Trotter disease, the cause is going to be the veins, right? The vein that is affected is going to be axillary vein thrombosis or subclavian vein thrombosis, and the cause is going to be repeated movement of the arms. Then prothrombotic state is again primary cause for upper limb DVT. Now after DVT, the next topic is going to be varicose veins. Now here you should know the course of great saphenous vein and the small saphenous vein. The great saphenous vein, it originates medial to the dorsal venous arch, then goes anterior to the medial malleolus along the medial course, and then it drains into the saphenofemoral junction FMGE, which is located 4 cm below and lateral to the pubic tubercle. Small saphenous vein, it originates from the lateral end of the dorsal venous arch, then it goes posteriorly and it drains into the saphenopopliteal junction, which does not have a constant site. It is determined radiologically. Then greater saphenous vein, it is associated with saphenous nerve. Small saphenous vein, it is associated with sural nerve. Perforators, the perforators in the thigh, they are called as the Hunterian perforators. The perforators in the above the knee, they are called as Torts, below knee birds. Then there are Cockett's perforators. So Cockett's perforators, there are 3. They are about 5 cm, 10 cm, and 15 cm from medial malleolus, and there are Hill's or May Custer perforators which are present in the heel. Total of 100 to 150 perforators are present in the leg. Then what are the risk factors for varicose veins? Again, long-standing patients. Generally, it is precipitated at the end of the day. Then it also has a familial preponderance. The gene that is involved is going to be the FOXC2 gene. Now, the most accepted theory is the ambulatory venous hypertension theory. Now, if it is only more than 3 millimeters in size, then that is varicose vein. 1 to 3 millimeter it is called as reticular vein, and less than 1 millimeter it is called as thread veins or dermal flares. What are the signs of advanced venous disease? In the signs of advanced venous disease, the first is going to be corona phlebitis, or it is also called as malleolar flare. So where the diverging flares less than 1 millimeter they can be seen. It's a sign of early advanced venous disease. Then atrophic blank, that is atrophic and no pigmentation at that particular site, surrounded by area having pigmentation. Then the next is lipodermatosclerosis. In the lipodermatosclerosis, there is going to be fat obliteration. Apart from that, the derma is also getting obliterated, and there is going to be complete sclerosis. So over here, it gives a champagne glass appearance. Then apart from that, ulceration, the venous ulcer can be seen. Now the next is the CEAP classification. The CEAP classification is clinical, etiological, anatomical, and pathological. So on the clinical basis, the C0, that means no varicosities are seen. C1 means it is 1 to 3 millimeters in size, that is retinal veins are seen. Then C2 is where the varicose veins are seen. Then C3 is edema. C4 is further divided as C4A, C4B, C4C. C4A means pigmentation. C4B is atrophic blank or lipodermatosclerosis. C4C, that is corona phlebitis. C5 is a healed ulcer, and C6 is active venous ulcer. Then etiological classification, either it can be primary etiology or secondary etiology. Anatomical classification, that is either AS, that is superficial veins, AD, that is deep veins, or AP, that is perforators are getting involved. And the pathological classification, either can be PR, that is reflux, PO, that is obstruction, or PRO, that is both reflux and obstruction present. Now, the clinical tests. The clinical tests are the SFJ incompetence, perforator incompetence, and the deep vein thrombosis. So the first, that is SFJ incompetence. In the SFJ incompetence test are the Morris's curve impulse test, Trendelenburg test, and Schwartz test. While in perforator incompetence, it is going to be the Figans test, Trendelenburg test, and multiple tourniquet test. For DVT, we have the modified Perthes test. On the investigation of choice is going to be the duplex. On the duplex, here we are going to get a Mickey Mouse structure, wherein the greater one is going to be the femoral vein. Then there is a common femoral artery and a great saphenous vein. Together it forms a Mickey Mouse appearance. Then the next is the management by using compression stockings. So grade 3 compression stockings of pressure 25 to 35 mmHg is used. Horse chestnut serial strat can be used. Then surgeries, there can be SFG incompetence. Trendelenburg procedure is done. In Trendelenburg procedure, there is a flush ligation of the vein that is done. There are about 6 tributaries: superficial external pudendal artery, deep external pudendal artery, accessory anterior saphenous vein, posterior thigh vein, then superficial epigastric and superficial circumflex iliac vein. And you have to do the stripping of the saphenous nerve until the T joint. Then saphenopoperial junction, there is going to be flush ligation of SPJ. Then in the perforator surgery, we have the bonds and pockets procedure, which is multiple superficial ligation, which is a very tedious procedure. Then the next is the SEPS, that is subendoscopic perforator surgery. In the superficial endoscopic perforator surgery, again all the perforators are ligated, but with one incision, and the contraindicated in Torres and Cockett's procedure. Then the next is EVLA procedure, that is endovenous ligation or EVLT procedure. Then in this particular procedure, the disadvantage is that a continuous pull out is required. Then the next is radiofrequency ablation. Advantages of this particular procedure is that the learning curve is small and continuous pull out is not required. Then the newer modalities that include the endovenous glue therapy. The glue that is used is the cyanoacrylate glue therapy. Then Trivex. In the Trivex, the transillumination is used. The orange color transillumination is seen with the help of this Trivex. Then foam sclerotherapy, or it is also called the Tessari technique. The agents that are used are the STDs, that is sodium tetradecyl sulfate, which is the most common polydoganol ethanolamine, and sodium moroate can be used. Then sclerosant to air concentrations 1:3 or 1:4. Then what are the complications of varicose vein? Lipodermatosclerosis, atrophic blank and all those things, ulcerations. Complications of varicose vein surgery. So earlier the most common complication used to be the wound infection, but nowadays it is not seen. Apart from that, hemorrhage, bruising can be seen, recurrence can be seen, but nowadays the most common complication is the injury to the nerve. If it's a greater saphenous vein, the most common injured nerve is saphenous nerve. If it's a small saphenous vein, then the most common injured nerve is the sural nerve. Associated syndromes. So the first is the Klippel-Trenaunay syndrome. In the Klippel-Trenaunay syndrome, it is found that the deep venous system is going to be vestigial in nature. Is it familial? No, it's not familial in nature, and there is no management required for it. Then the next is the Parkes-Weber syndrome. In the Parkes-Weber syndrome, multiple arteriovenous fistulae are seen. Because of multiple arteriovenous fistulae, it can lead to high output cardiac failure and hypertrophy of the limb is seen. Then venous ulcer. The most common site of venous ulcer is the gateless area. It is found above the medial malleolus. Pulsation, it is seen. Sensation are intact. Then the edges, they are sloping in nature. The margins are pigmented, and a pale granulation tissue is seen, which is suggestive of non-healing nature. Then the conservative regime is called as the Biscard regime. In the Biscard regime, there is education, elevation of the limb, and elastic compression stockings. The only drug that is involved is the pentoxifylline. The pentoxifylline, it is approved because it has increases the microvascular perfusion. Then the next is arteries. The first topic in the arteries is arterial occlusion. It is divided into two, that is acute arterial occlusion and the chronic arterial occlusion. Acute arterial occlusion, the most common cause is going to be the embolus. The most common source is going to be the heart, and the risk factors are going to be coronary artery disease and atrial fibrillation. The clinical feature, it consists of 6 P's, that is pain, pallor, paresthesia, poikilothermia, that is cold limbs. But very important, two things, that is pulselessness and paresis. Pulselessness and paresis are considered to be the lead signs. Then investigation of choice is a duplex scan. Management: if the patient comes within 6 to 8 hours, then thrombolysis is done. The thrombolysis is done with the help of thrombolysis, or embolectomy is done. Embolectomy is done with the help of Fogarty's balloon. So this is the Fogarty's balloon. If the patient comes up late, then it comes with a complication that is called as gangrene, and for that amputation is the only thing. Then reperfusion injury. What do you mean by reperfusion? Once thrombolysis or embolectomy is done, then a normal blood flow is restored. The free radicals that are generated in that area, they can move to the distal compartment, so that is lead to free radical injury. Then compartment syndrome. Compartment syndrome, the pressure that is required is more than 30 mmHg. The clinical features of compartment syndrome are pain on passive flexion, and the management for this compartment syndrome is going to be fasciotomy. The next is the chronic arterial occlusion. In the chronic arterial occlusion, the cause, it is most common, is going to be atherosclerosis. Then distal runoff is seen. Distal runoff is seen because of the development of collaterals within the time period. The clinical features are intermittent claudication. Suppose the patient will have intermittent claudication where the pain will be upon doing some certain amount of exercise, then the claudication distance will decrease, then it will progress to rest pain. Then the patient will hang his legs from the bed at night, and finally it will lead to gangrene. Differential diagnosis for this intermittent claudication, it can be neurogenic claudication upon change of posture. So generally the patient feels relief when he bends forward. So during walking upstairs, he feels relief. Walking downstairs, there is a pain. Or osteoarthritis. Osteoarthritis, however, there is a pain during the first step itself. The classification, there are two important classifications of the arterial occlusion. So the first is going to be the Boyd's. So in the Boyd's classification, class 1, the patient feels pain on walking, but however eventually decreases because the substance P is washed out. In class 2, the substance P does not get washed out, so the pain persists, but he can complete his goals. In class 3, the pain forces the patient to stop, and in class 4, there is a pain at rest. Now similarly, there is another classification that is called as Fontaine's classification. The Fontaine's classification also has 4 classes. So in class 1, it is asymptomatic. In class 2A, there is a mild claudication, but however the patient can walk for more than 200 meters. Then in class 2B, there is moderate to severe claudication less than 200 meters. Class 3, there is rest pain, and class 4, there is the ulceration or gangrene that is seen. Now, the types or the characteristics of this ischemic pain is that there is a pain at rest. Then this pain relief happens by hanging the legs down because the gravity helps in the flow of blood. The night pain worsening, due to night pain worsening is seen because there is a decreased cardiac output during the night time, as well as the limb temperature drops. Now, the ulceration that is seen is the arterial ulcer, which is most commonly seen at the level of tip or at the level of pressure points. then it is very painful in nature. There is a punched out appearance of this ulcer. The pulsations, they cannot be felt in arterial ulcers, however the sensations are intact. There is a lack of granulation of tissue which suggests that it is non-healing in nature. Then there is a certain systemic involvement. There's a way in which the systems get involved. The first is coronary artery disease that will lead to chest pain. Cerebrovascular accidents, transient ischemic stroke or attack can happen. Then renal artery thrombosis. Then it will lead to erectile dysfunction, and further it can lead to other systems involvement. Then diabetes and smoking are the very important risk factors. Now, the next important thing is site. On the basis of site, we can determine the site on the basis of the symptoms. The first is the aortoiliac obstruction. In the aortoiliac obstruction, the clinical features are the patient will have bilateral buttock pain and thigh, calf, and all the distal muscles pain. The pulses, they cannot be felt in the femoral region. However, there can be iliac bruit that can be heard, and the syndrome is called as the lyric syndrome, wherein it will also lead to impotence in the individual. Then the iliac obstruction. In the iliac obstruction, it is unilateral in nature. There will be sometimes buttock pain will be involved, but most commonly thigh pain and calf pain is present, and the femoral veins over here also cannot be pursued. Then femoropopliteal obstruction. The femoral pulses can be pursued. It is unilateral pain. There is no thigh pain over here. There is pain in the calf region, and there is pain in the distal muscles. In the distal obstruction, there can be pain in the distal muscles. There is no calf pain, and it's generally because of any artery that is present distally. The complications are arterial ulcer. We have already discussed about this arterial ulcer. The investigation of choice is going to be a duplex scan. Now there is something called as ABPI, that is ankle brachial pressure index. Ankle brachial pressure index normal value is 0.9 to 1.4. If it is less than 0.9, then that means there is intermittent claudication. If it is less than 0.4, then that means CTLI, that is chronic limb threatening ischemia. There is ischemic rest pain and plus minus ulceration or gangrene can happen. If ABPI value is more than 1.4, now this can be seen in case of diabetes mellitus, it can be seen in calcification, or it may be seen in sclerosis and chronic renal failure. So in these particular cases, we go for toe brachial pressure index. Toe brachial pressure index and ankle brachial pressure index is seen. Toe brachial pressure index is seen because the distal arteries are generally resistant to calcification or sclerosis. Right? If the toe brachial pressure index, if it is less than 0.6, in that particular case there is going to be severe ischemia that is present. Digital subtraction angiography is done only if the intervention is planned in that patient. Now the next is the chronic arterial occlusion. It is caused either because of Burgess disease or atherosclerosis. What's the difference? The Burgess disease is also known as thromboangiitis obliterans. Now gender predilection. The Burgess disease is more common in males as compared to females, while atherosclerosis, very important, it is equal in males as well as in females. Age group in the Burgess, it is either 3rd to 4th decade of life, while atherosclerosis is found in more than 5th decade of life. Then the risk factors for Burgess disease is going to be smoking. In atherosclerosis, smoking is also seen. So smoking is a common risk factor for both. But apart from that, alcohol, type A personality, and all this come. Then talking about the limbs, both of them, lower limb is greater than upper limb. Then the structures involved are in Burgess disease, artery, vein, as well as nerves is getting involved. So arterial occlusion will take place, that will lead to ulceration and gangrene. Venous occlusion will lead to thrombophlebitis, and the nerves are getting affected, it will lead to neuropathy. While in atherosclerosis, only the arteries are getting affected. The spread of the Burgess disease is from distal to proximal, while in atherosclerosis, proximal to distal. The vessels that are involved in Burgess disease are going to be smaller vessels, right? While in atherosclerosis, it's large to medium sized vessels that are getting involved. The management of the Burgess disease is, in the Burgess disease, the best management can be the smoking cessation. The pentoxifylline can be given. Other conservative measures can be done, but however, if there is a rest pain, then we go for lumbar sympathectomy. Now, if the Burgess disease is present in bilateral limbs, in that condition, bilateral lumbar sympathectomy, if it is planned, then you have to preserve the L1. Why? Because that can lead to impotence in that individual. Then this lumbar sympathectomy, it's contraindicated if there is going to be intermittent claudication. So if intermittent claudication, you have to manage it conservatively. Only if rest pain is present, the lumbar sympathectomy is done. Atherosclerosis, very important. In Burgess disease, there is no angioplasty or grafting that is done. Atherosclerosis, the first line is going to be endovascular stents, that is angioplasty. If it fails, then bypass grafting. Now, bypass grafting is of two types, suprainguinal and infrainguinal. Suprainguinal bypass grafting, it consists of aortobiofemoral grafting. It is done in aortoiliac obstruction. But if there is iliac obstruction or if there is femoral block, if it's iliac block, then we go for aortofemoral grafting. If it's a femoral block, we go for iliopopliteal grafting. Now, the material used for suprainguinal grafting, that is aortobiofemoral, the material used is the Dacron. Only synthetic material is used. For infrainguinal grafts, the natural material, that is reverse grade saphenous vein graft, can be used, or the synthetic material, that is Teflon, can be used. Now, moving on to the next, amputation. The black color in the gangrene. The black color in the gangrene is formed because of hydrogen sulfide. Now, what are the indications for amputation? The indications for amputation are dead, deadly, and damn nuisance. So, dead, that is the limb that is already turned gangrenous. Then, for deadly limb, the mnemonic is C atom. So, the C atom mnemonic stands for cellulitis, then AV fistula, wet gangrene, trauma, and osteomyelitis. Dam nuisance is PCR, that includes the paralysis, contracture, and the rest pain. So these are the indications for amputation. Then in diabetes mellitus, there is a amputation of the digits that is done. For metatarsalophalangeal joints, there is a ray excision that is done for several toes when they are getting affected. Transmetatarsal excision is done. Above knee amputation and below knee amputation. Above knee amputation, it helps in better healing, while below knee amputation, it helps in better mobility of the patient. For above knee amputation, long anterior flap is recommended. For below knee amputation, long posterior flap is recommended. The stump length for below knee amputation should be more than 8 cm, ideal 10 to 12 cm. For above knee amputation, the stump length should be more than 20 cm. There are different types of amputation. The first is surgical amputation, that is done for gangrene patients. Medical amputation is because of the drugs, or it is because of frostbite. Then congenital amputation because of amniotic band syndrome, and accidental because of road traffic accident or any machineries. Then what is myodesis versus myoplasty? Myodesis is nothing but a fusion of the muscles, while myoplasty, it actually means the opening of the opposing of the muscles. The opposing muscles are sutured. This is myoplasty, generally done in peripheral vascular diseases. Now, the skin flaps. The skin flaps are further divided as short flap and long flap. Short flaps are about broader at bases. The longer flaps, they are taken from the compartment which has a more bulk. For example, posterior compartment of the leg. Then the length of the flap, as said, in above knee and below knee amputations. The complications of amputation. The complications of amputation in the skin region, it can lead to ulcer, that is called as Douglas ulcer. It can lead to painful scars. In the subcutaneous tissue, it can lead to abscess. In the muscles, it can lead to contracture. In the bones, it can lead to osteomyelitis. In the joints, it can lead to arthritis. Arteries, it can lead to hemorrhage or hematoma. In the veins, deep vein thrombosis. And the nerves, it can lead to neuroma and phantom limb. Then there is something, and also mental problems can happen because of socio-economic and all those reasons. Then guillotine amputation. Guillotine amputation means everything is cut at the same level. In guillotine amputation, all the tissues, they are cut at the same level, which is generally preferred in children. It is contraindicated in case of adults. Now there are different levels of amputations. So the first is going to be the ray amputation or the ray excision. The ray excision, that is done for phalanges, and the incision that is done, that is called as the tennis racket incision. Then the Gillies amputation is transmetatarsal. Then above it, connecting the tarsal muscle to the metatarsal, that is tarsometatarsal amputation, that is less frank. Then Chopard's amputation is mid-tarsal. Then Simmons disarticulation is from the ankle joint. Then below knee, it is called as the Burkiss procedure. Long posterior flap is used. Then peg leg, it is done 3 cm below the tibial tuberosity. And then the grid strokes. The grid strokes is done transcondylar at the level of tibial condyles. The patella is preserved. Then above knee amputation, long anterior flap is done. Stump length of minimum 20 cm is kept. Then hip disarticulation. And then the next is the Taylor's procedure where hemipelvectomy is done. So these are the different levels of amputation of the lower limb. Now, what should be the characteristics of an ideal stump? The ideal stump, the skin over the stump should be mobile.
over the deep tissues. Adequate tension should be present. Thin, painless, and mobile scar should be present, and there should be full range of motion at the proximal joints. Now talking about the prosthesis. So in the prosthesis, there are lower limb prosthesis and upper limb prosthesis. In the ankle, we have the series prosthesis. Then we have such prosthesis. Such prosthesis is nothing but solid ankle cushion. The solid ankle cushion, it is made up of it is actually the inversion and eversion does not happen. Then rubber prosthesis, that is called Jaipur rubber prosthesis. So that is most commonly used because inversion eversion is possible, as well as dorsiflexion and plantar flexion is possible. Below knee amputation, above knee amputation. In below knee amputation, we use the patellar tendon brace. Above knee amputation, there is a conventional prosthesis that is used, and suction socket prosthesis. And in hip disarticulation, there is a Canadian prosthesis that is used. Then MESCO, uh, that is mangled extremities severity score. Mangled extremity severity score, if it is more than 7, then that is an indication for amputation. Now the next is going to be the Raynaud's phenomena. So there are 3 phases of Raynaud's phenomena. In the first phase, the limb becomes white in color, then blue in color, and then red in color in the third phase. So in the first phase, it becomes blue in color because, in the first phase, it becomes white in color because both the arteries and the veins, they are going to be blocked. Then in the second phase, it becomes blue in color because the artery, it relaxes while the venous spasm is continued. In the third phase, both artery and the venous spasm is relieved, and because of which it becomes red in color. Now, what are the differences between primary Raynaud's phenomena and secondary Raynaud's phenomena? The prevalence is common in primary Raynaud's. Then family history is present in primary Raynaud's. Then association with rheumatological conditions or ANA antibodies, it is present in secondary Raynaud's disease. Then pharmacological treatment, it is generally done in case of secondary Raynaud's disease. And the complications like gangrene, they are present in secondary Raynaud's disease and not with primary Raynaud's generally. And the drug of choice that is generally asked is calcium channel blockers. Now there is something called as subclavian-Steele syndrome. The causes for subclavian-Steele syndrome, they are going to be the stenosis in the first part of subclavian artery. It is most common because of thrombosis, that is atherosclerosis, or secondary to thoracic outlet obstruction. The pathophysiology is that during exercise, there is a retrograde blood flow from the vertebral artery that will lead to multiple syncopal attacks. The management over here is angioplasty. Then the next topic is aneurysm. The most common type of aneurysm is the fusiform type. The most common vessel that is involved is going to be the circle of Willis. The most common extracranial vessel that is involved is the infrarenal part of the abdominal aorta. The most common peripheral vessel, that is the popliteal vessel. Then the most common visceral vessel is the splenic artery. Mycotic aneurysm, it is most commonly seen because of the staph aureus, and the vessel involved is going to be the aorta. Then the most common site for traumatic aortic aneurysm. The most common site for traumatic aortic aneurysm is going to be the descending thoracic aorta. Now abdominal aorta. The risk factors for this is going to be the atherosclerosis. The critical diameter for ascending aorta is 5.5 centimeter. For descending aorta, it is 6 centimeter. For abdominal aorta, again 5.5 centimeter, and for Marfan syndrome, it is 4.5 to 5 centimeter. In case of females, it is 0.5 centimeter less in every artery. Then there is a Bluetooth syndrome. Bluetooth syndrome is caused because of the multiple bits of emboli that are blocking the T vessels and toe vessels and leading to gangrene. Then rupture of aneurysm. If there is a rupture of aneurysm, most commonly ruptures, and there is a hemorrhage that happens into the left retroperitoneal region. The investigation of choice is going to be the CT angiography. Now conservative management is done if the patient is asymptomatic and if the size is less than 5.5 centimeter. If the size is more than 5.5 centimeter, and even if this patient becomes asymptomatic, then also intervention is done. There are 2 types of surgeries: open graft surgery or EVAR procedure, that is endovascular aneurysm repair. The open graft surgery is generally done in case of young patients where more life expectancy is expected, while the EVAR technique is generally done in case of old patients where hostile abdomen is present, and high risk patients are generally done. EVAR is contraindicated in case of difficult access and where the angulation of the iliac vessels is more. This is according to the NICE guidelines. Now the complications. Are the endo leak. Now
Out of there are total 5 types of endothelium, out of which type 1 and type 2 is important. Type 1 is seen in thoracic aorta aneurysm repair, and type 2 endothelium is seen in abdominal aorta aneurysm. In the type 1 it is because of improper seal, and type 2 it is a retrograde type of leak. Then there are different maneuvers that are performed to visualize the abdominal aorta. So the first is a Mattox maneuver. In the Mattox maneuver, the left colon, that is the descending colon, it is medially rotated so as the abdominal aorta is visualized. Similarly, cattle brush maneuver. Cattle brush maneuver is used to visualize the inferior vena cava. For that, the right side is medially rotated. Right, it is generally done in case of renal cell carcinoma which metastasizes to the inferior vena cava. Then there is cauterization procedure. Cauterization procedure is nothing but mobilization of duodenum. And what are the complications of surgery? The most common cause of death is the cardiovascular complications. Renal failure can happen if suprarenal part is affected. Then the fistula formation can happen, which is one of the rare complications. Aortoduodenal fistula can happen, that can lead to upper GI hemorrhage. Then colonic ischemia is seen because of aneurysm. Generally, the left-sided colon is affected, and because the splenic flexure is going to be a watershed area. Paraparesis is seen. This is seen because because this abdominal aorta is going to supply an important artery, and that is called as the artery of Adam Kivis. Artery of Adam Kivis, it supplies the anterior spinal artery, and because of which it leads to paraparesis. And the mortality chances, I would say elective surgery, that the mortality chances are 2 to 3%, but however it's a emergency surgery, then the mortality chances are about 50%. Then the thoraco-abdominal aneurysm. The classification used is known as the Crawford's classification. There are 4 types. Type 1, where it extends from the left subclavian to the renal artery. Then in the type 2, it extends from left subclavian up to the bifurcation of the aorta. This is the most extensive type. And type 3, from the mid descending aorta to aortic bifurcation. And type 4, from upper abdominal aorta to the infrarenal aorta. Then causes, it is generally secondary to atherosclerosis. Then clinical features are going to be the same. Only the pressure symptoms are seen: dysphagia, dysarthria, and Ortner syndrome, where there is going to be a hoarseness of voice because of left recurrent laryngeal nerve getting involved. Then graft repair is generally done. Investigation of choice remains the same, that is CT angiography. Now talking about the aortic dissection. The pathology for aortic dissection is the aortic aneurysm getting which is triggered by hypertension. So there is a parallel flow of blood in the opposite direction. So there is a bidirectional flow of blood that is seen. The most common site is going to be the lateral wall of the ascending thoracic aorta. Then the risk factors: hypertension and aortic aneurysm. This is caused because of tear in the tunica intima. Okay, and then there is another called as pseudo dissection, wherein tunica intima as well as tunica media both are getting involved. Then most common symptom for this is going to be chest pain, which is radiating to the back. Then it is more commonly seen in males. There is a pressure change, difference in the BP that is seen in the upper limbs and in between the upper limb and the lower limb. On the chest X-ray, there is a mediastinal widening that is seen, coronary insufficiency. And the next, that is investigation of choice. In stable patients it is contrast and CT. In unstable patients it is transesophageal echocardiogram, that is TEE. Classification, there are 2 classifications: Stanford's classification and DBK classification. Now in the DBK classification there are class 1, 2, 3. In class 1 there is both ascending and descending thoracic aorta. In class 2 there is ascending thoracic aorta, and class 3 there is descending thoracic aorta. Class 1 and 2, they are together called as Stanford's class A, and the third is called as Stanford's class B. Now the management, the first step is going to be given, that is short acting beta blockers, that is called as the esmolol. This is done for permissive hypotension, so that the BP is around 100 mmHg systolic, and then the surgery is done based on the classification. If the class is type 1 and 2, then that is the ascending aorta is getting involved. In that particular condition, thoracotomy and graft repair is done. If it's going to be a class 3 where only descending aorta is getting involved, in that particular condition we can go for conservative management, and if it fails, then go for thoracotomy and graft repair. Then the most common peripheral vessel that is getting involved is the popliteal aneurysm. Popliteal aneurysm comes as a swelling at the back of the knee. Management is graft repair. It is done in symptomatic patients, or
asymptomatic patients where the size is more than 2 centimeter, 2 to 3 centimeter. Femoral artery, the causes for femoral artery here is iatrogenic because of cannula insertion or because of line or central line insertion. If it is less than 3 centimeter in size, then thrombin injection is given. If more than 3 centimeter, then surgical graft repair is done. Carotid artery aneurysm, the most common site is going to be the aortic bifurcation. The cause, atherosclerosis. Most common presentation in carotid artery aneurysm is going to be transient ischemic attack to the patient, blackouts. The management over here is carotid endarterectomy, and indications for this, they are going to be stenosis of more than 70% with blackouts, facial paralysis, arm leg paralysis, anything like that. Investigation of choice is duplex scan. Now there's pseudoaneurysm that I already said, where the tunica intima and the tunica media is getting involved. USG Doppler sign that is seen, and bidirectional blood flow is seen. So the characteristic ultrasound Doppler sign that is called as the yin-yang sign. Now the next is the thoracic outlet obstruction. The structures that are compressed are the subclavian vessels and the brachial plexus. The risk factors for which is going to be the cervical rib, then weak musculature and trauma. The clinical features over here is the subclavian artery can undergo thrombosis, subclavian vein thrombosis that is called a pressure shorter disease, and brachial plexus compression. The most common nerve that is getting involved is the ulnar nerve. Then the test, that is Adson's test. In Adson's test, the arm is abducted up to 30 degree with arm straight, and we have to check for the pulse of the patient. While doing so, there is a decrease or absence of pulse that is seen. Then the East test, that is elevated arm stress test or Rule's test, where ask the patient to place the arms in the surrender position and to intermittently close the fist and open the fist. This will increase the pain. Then LV's test, these are the 3 position tests, where the first position is the arm abducted to 90 degree with elbow flexed, and position 2 is active dorsiflexion of both the wrist. In position 1 and 2, they are used to elicit the ipsilateral symptoms. Now position 3 is head is tilted to the both sides. This is done for eliciting the contralateral symptoms. Now Wright's test is also done. Management, if it's a case of arterial block, then in that particular case the stenting is done, venous block, anticoagulation, and if the cervical rib is present, we have to excise the cervical rib. And next is the sarcoid aneurysm. In sarcoid aneurysm, the most common site is superficial temporal vessels. There is a large pulsatile swelling that is seen. Then AV fistulae. The AV fistulae, they are generally seen in congenital conditions like Sturge-Weber syndrome or Park-Weber syndrome. It is seen in the intestine iatrogenically for renal dialysis. Most common is the Seminous fistula that is done between the radial artery and the cephalic vein, that is called a radiocephalic fistula. Then the sign of this is going to be Nicola-Doni sign or the Branham sign, the Brahman sign. So Nicola-Doni sign or the Branham sign. This means that if we press on the feeding vessel, and the size of fistula will decrease, the pulse rate will decrease, bruit will decrease, pulse pressure will be normalized. Only thing that increases is the systolic blood pressure. Imaging investigation of choice is MR angiography. Digital subtraction angiography is done only with the intervention is planned. Management in this condition is embolization, and if it's a case of IV drug abuse, then surgical excision or ligation is done. Then coronary artery bypass grafting indications are, it's a left main disease involving more than 50%, then 3 vessel disease involving more than 70%, 2 vessel disease or 1 or significant stenosis greater than 70%. Then the CABG grafts that are used are reversed great saphenous vein graft, which is the most common graft, Lima-Lad graft, that is used for left anterior descending artery, Rima graft, or radial artery grafts. So these are the different grafts that are used. Now the next topic is going to be the lymphatics. So starting with the embryology, the lymphatics, they generally originate by about 6 to 7 weeks. There are 4 cystic spaces, 2 in the neck, that is jugular lymphatics, and 2 in the inguinal region, so inguinal lymphatics. The drainage, the head and neck, it drains into the right internal jugular vein. The lower limb and abdomen, it drains into the cisterna chyli, which forms the thoracic duct, and it drains into the left internal jugular vein. The unilateral flow of the lymph, it's maintained because of the walls, bicuspid walls, and muscle contracture and the lymphangiones. The cystic hygroma, the most common site for cystic hygroma is the posterior triangle of neck. Other sites is the axilla inguinal region. It is partially compressible in nature. Compressible in the sense that when we apply the pressure, it compresses. Upon release of pressure, it will immediately come back. It is fluctuant, transluminant. The clinical features are it can lead to obstructed labor, respiratory distress, or infections can happen. It is generally noted on prenatal imaging. Investigation of choice is going to be the FNSE, and the management is surgery, surgical excision. If it's a case of large cystic hygroma, then sclerotherapy is given and it is made small. The most common nerve affected is the spinal accessory nerve, leading to drooping of shoulders. Acute lymphangitis, as shown in the given picture, is a reddish streak that can be seen, because of which the most common positive organism is going to be streptococcus or staphylococcus, and the treatment is going to be antibiotics and limb elevation. Now the next topic is lymphedema. In the lymphedema, the pathology includes the uh, improper drainage of the interstitial fluid. Now there are different types, primary and secondary, out of which secondary is more common. So in primary lymphedema, it is actually caused because of increased interstitial fluid production, and secondary it is caused because of increased interstitial fluid production, or there is a damage to the drainage. The secondary lymphedema is more common as compared to the primary lymphedema. In secondary lymphedema, there is increased interstitial fluid production because of inflammation, or there is a decreased because of there is a damage to the drainage because of post-surgery or infection. Now, the long-standing cases of lymphedema, uh, it can lead to chronic skin changes. Will be discussed further. The classification is called as the Brunner's classification. The Brunner's classification, the stages are 0, 1, 2, 3. In 0, there is excess interstitial fluid production, which is subclinical or latent. In 1, there is a pitting edema. In 2, there is non-pitting edema. And in 3, the edema is associated with irreversible skin changes. So what are those skin changes? So the first skin change that is denoted over here, that is the buffalo hump. The buffalo hump is the loss of contour of the ankle or the medial malleolus. Then squaring of toes can be seen. Then we can't pinch over the dorsum. So can't pinch over the dorsum. This is called as the Stammer's sign. Apart from that, if the lymphedema is not taken care of and it persists for 8 to 10 years, then there are chances of lymphangiosarcoma. That is angiosarcoma. This angiosarcoma is present as nodules, and this syndrome is called as the Stewart-Travis syndrome. The Stewart-Travis syndrome, angiosarcoma, it is common post mastectomy. Management is by doing aggressive surgery or amputation. Investigation for lymphedema. For investigations for lymphedema, the gold standard is going to be water plethysmography, where we measure the amount of water displaced. Mild less than 20%, moderate 20 to 40%, and severe more than 40%. Radiologically, we do it with the help of lymphangiography. In the lymphangiography, we come to know whether it's a distal obstruction, proximal obstruction, or congenital hyperplasia. Then single axial CT of the midcalf can be done. This helps to differentiate between the lymphedema, venous edema, or lipoedema. The lymphedema, it shows a reticular honeycomb appearance. Now primary lymphedema. The primary lymphedema, it is of three types: lymphedema congenita, the most common, that is the lymphedema precox, and the lymphedema tarda. Lymphedema congenita is found in 0 to 2 years of age. Then lymphedema precox, it is seen in 2 to 35, and tarda is seen for more than 35 years of age. Very important are the familial syndromes that are associated. The familial syndrome that is associated with lymphedema congenita, that is Noonan-Milroy syndrome. And the one that is associated with precox is the mixed syndrome. In the precox, generally it leads to unilateral edema in the lower limbs, while in congenita it involves the face, buttocks, lower limb, everything, abdomen. Then secondary lymphedema. The most common cause of upper limb lymphedema is post-mastectomy. Also, this is the most common cause of lymphangiosarcoma. The most common cause of lower limb lymphedema, and which is the most common cause of overall lymphedema, is going to be filariasis. Now, what is lymphangioma? The lymphangioma is nothing but is a chronic skin change that is seen secondary to lymphedema. There are nodules that are seen. So it is divided into three types: lymphangioma circumscriptum, where the size of nodules is less than 5 cm; lymphangioma diffusum, where the nodules are more than 5 cm; and lymphangioma ab ignae, where there are reticular arrangements that are seen. Management, conservative management is pain relief, skin care. Skin care, very important, most important point, that a dry skin is more prone to infections. Then Decongestive lymphedema therapy. It consists of two phases, first phase and second phase. First phase is under the supervision of doctor. Second phase is done at home. So in the first phase, there is MLT, that is manual lymphatic drainage. Manual lymphatic drainage is done by massages, limb elevation, or pneumatic compression stockings. MLLB, that is multi-layer lymphedema bandaging. It is done after ruling out ABPI. And the second phase, as I said, done in the home maintenance phase. Surgeries that are done if it is not treated conservatively. Reconstructive surgery where a lymphovenous anastomosis is done. This is called as Nepilovitz procedure. Nepilovitz procedure. Then the resective surgeries that include the Thompson's reduction operation. The Thompson's reduction operation, the complication for which is going to be the pilonidal sinus. Then there is a Charles procedure. The Charles procedure is where the split thickness skin graft is done. It's the worst procedure because it leads to multiple cosmetic complications. So cosmetically it is very worse. Other is the Homan's procedure. In Homan's procedure, the skin resection is done, wedge resection is done. The most common complication is going to be the skin necrosis. So this is everything about the vascular surgery.